All right. This is a cardioprotection study that was presented at AHA. This was not published. This was done by a group out of Norway. So it's a randomized control trial looking at cardioprotection after chemotherapy with ACE inhibitors or beta blocker. Or actually, I should say it's an ARB. It's an angiotensin receptor blocker. Okay, so the first author is a Gulati. There's actually two Gulatis in the field of imaging and oncology. This is the group out of Oslo, Norway. So the background, anthracyclines and trastuzumab are obviously, they're well-known cardiotoxic medications that are used for chemotherapy. Trastuzumab is known as Herceptin, and that tends to be a reversible, we tend to think of that as a reversible cardiomyopathy. However, the anthracyclines are probably what causes the most long-term problems in patients that undergo chemotherapy with anthracyclines. There's acute, subacute, long-term effects, and I think we've probably all taken care of patients that have cardiotoxicity from anthracyclines. To give you an idea of the incidence of cardiotoxicity with anthracyclines, there was a recent paper, very nicely done, that involved about 2,600 people, and they found that they followed these patients every 3 months with echo, and they found that the overall cardiotoxicity rate with anthracyclines is about 9%. And most of the cardiotoxicity occurs within the first year. And treating these patients early, once you discover that there's cardiotoxicity, getting them on ACE inhibitors and beta blockers was crucial in recovery. And about 25% of patients had a full recovery, and 71 patients had partial recovery. So randomized control trials looking at cardioprotection are not new. Welcome. So there's been a number of randomized control trials looking at cardioprotection, and here's an example of a few. The first study looked at carvedilol, showing that if you put patients on carvedilol after 6 months, the EF in patients that underwent anthracyclines tends to be much better than control. Same thing was shown with nabivolol at 6 months, that the EF was higher. Same thing with enalapril. So I'm not going to go through these in detail, but you can see there's been a number of studies looking at cardioprotection in patients that undergo anthracycline therapy. This was another systematic review, and these are the cardioprotective agents. There's actually something that's used pretty commonly in the pediatric world. It's called dexrozoxane, and this is an iron chelator. However, the FDA has been quite skeptical about this, and it hasn't been used in adult patients. But these are all studies that looked at this iron chelator in pediatric populations. And then again, these are some repeat randomized control trials and observational studies that basically show that patients that undergo chemotherapy do better with cardioprotection, whether it's, go ahead, Matt.
Do you mind just commenting on the mechanism or thought mechanism of the anthracycline toxicity and why iron chelator works?
Yeah, honestly, I don't know.
There's iron, free radicals.
Yeah.
And iron handling.
So probably ROS, a reduction of reactive oxygen species.
Anthracycline is very similar to alcoholic cardiomyopathy. And I don't think people really know. And so that's the potential possibility that would cause
Yeah. And I think when we see long-term EF drops in patients that were exposed to anthracyclines, there probably was toxicity the entire time that just went unrecognized. And that's why, people are starting to look at strain imaging and other imaging modalities to identify it earlier. And then this has been meta-analyzed, systematic reviews. And basically, this table is obviously quite confusing, but just to show you that this iron chelator favors the intervention versus the placebo in a number of studies, again with beta blockers, favorable versus placebo. Statins, there's been a number of statin studies as well, favorable, and ACE inhibitors. A lot of these are small studies, so it segues into the study here. So what made the PRADA study different? It wasn't that big of a study, so it had 120 breast cancer patients, but it was a homogeneous group, so they called it the largest group of like a homogeneous population, and they also used MRI imaging. So the hypothesis was patients undergoing breast cancer therapy, a decline in cardiac function can be prevented by using metoprolol and/or candesartan. So they included 120 women, baseline EF of 60%, and they powered it. And they actually did what's called a 2x2 factorial randomized placebo factorial study, which looks at, I'll show you the slide next, but it's going to look at candesartan and metoprolol combined in one arm, candesartan alone, metoprolol alone, and then placebo. And the medications were started before the anthracyclines, so the intervention was given at week 0, and that was after they had an MRI as a baseline assessment. And then it was continued throughout the course of chemotherapy. And because it's breast cancer, some of those patients were HER2 positive and went on to get trastuzumab as well. And the HER2 negatives went on without trastuzumab. End of the study occurred at 10 to 64 weeks, so maybe a little bit longer than some of the prior studies. Inclusion criteria, this is basically a healthy population, so they excluded a lot of the people with prior CAD, and it's actually a very healthy population. An ECOG performance status of 0 to 1, that's a healthier population. Exclusion criteria, patients that required chemotherapy in the past, patients with heart failure, CAD, valvular disease, arrhythmias, and then anybody that received an ACE inhibitor recently or a beta blocker recently was also excluded. So the primary endpoint was change in LV ejection fraction by cardiac MRI. And here's the schematic for how they randomized. So they started with 344, and that was narrowed down to 130 after exclusion criteria. 10 patients missed the MRI at baseline, and then they were randomized to either a combination of beta blocker and ARB, or the ARB alone, metoprolol, first placebo, and then placebo. All right, so the primary outcome was a decline in LVEF, and in the candesartan group, there was a drop of 0.8%, and then when you compare that to the placebo group had a drop of 2.6%, so this is actually quite modest compared to the prior randomized control trials, but one may argue that this is a healthier population at baseline, and this is a little bit more rigorous than the prior studies that I showed you. So the between group interaction was significant, and then they noticed that metoprolol was not associated with a change in LVEF versus placebo. And here's the forest plot showing that candesartan was significant, did not include the null. And by subgroup analysis, nothing stands out too much, although patients that were older tended to do better with cardioprotection. Patients with a higher BMI did worse, and this may be because they received a higher dose of anthracycline because it's weight-based. And then the metoprolol was not significant. So the clinical implications, so this is, again, this is a cardioprotection trial where ACE inhibitors and beta blockers were looked at prior to giving chemotherapy, anthracycline-based, and patients that were on ACE inhibitors, or ARBs actually, did better with regard to the primary endpoint. So the strengths were, it's randomized, placebo-controlled, They looked at serial imaging with cardiac MRI, which was unique compared to the prior studies, and a decent sample size compared to the prior studies that looked at this. And the limitations were the follow-up length was not that long, and this was a pretty low-risk group, so probably their numbers may not have been as high as they had anticipated. Yes?
So, why can you comment about, as they mentioned in their presentation, if those cancer patients, they have evolution, have not like genetics, because we don't know, with 20 patients, 25 patients in each group, very hard to tell which one is going to have a predisposition for chemotherapy-induced cardiomyopathy, versus the best, and we take quite a, or we ameliorate or decrease the effect by increasing the sample size 20 patients and make sure that all of them have the same ability to cardiomyopathy. Have they mentioned anything about that?
So the final paper is not published, but there was no mention of genetic testing. If that's what you're looking at.
People would love to be able to do that, but I don't think anybody can adequately risk stratify someone going into chemo other than like the known gap junction genes, like from cardiomyopathy. But that would be, there are some, it's totally unrelated to this, but there are some people that are doing microarray analyses, look for genetics now, trying to pull out genes that people that might be susceptible, but I don't think right now people can determine certain. So the only way of going in is just by forming things. All the people look pretty same, they don't have any known cardiomyopathy, so they're all similar risks. We don't know.
And I think, all right, people find, yeah, see imaging characteristics that we can predict, you know, the drug that they have. One of the studies.
Well, I haven't seen combinations for.
Yep. But they don't report the different groups, so it's either patients that received candesartan, which, as you know, half of them received candesartan alone, half received candesartan and metoprolol. So that's not how they report. And that's not uncommon for a 2x2 factorial. Like if you look at POISE-2, aspirin versus placebo and clonidine versus placebo, it's, that's how they report out in the primary analysis. So for these initial slides that they showed us, we don't know the breakdown of all the subgroups.
Essentially means anybody on candesartan, whether they were on metoprolol or not.
Yeah, exactly. So the question is there do we know if there's any interacting effect? And you can't tell just based on these preliminary slides because the final study's not published. It could be that there is interaction because we've seen prior randomized control trials where beta blockers are beneficial. So there could be synergy. I agree. Yeah. Anybody else?
The other thing I can say is anecdotally, talking to Dr. Nisov, he said that he absolutely initiates those beta blockers and cardiac chemotherapy, which I think is interesting, because I don't think that it makes sense. Everybody would agree that it makes sense.
Yeah, and I think with 9% incidence rate of developing cardiotoxicity, that's quite high. I think most people would argue.
Just a question on the design of this thing. At the end, when they did the measurements, was everybody off of the drugs for a long period of time? They can't start with the beta blockers?
Yeah. My understanding was they stayed on it the entire time.
So if you just gave regular people these things without any chemotherapy in between, would it affect their injection effect?
Yeah, I suppose there is no control group.
I'm just curious, whether they got the hemodynamic effects as opposed to,
That's true.
True damage.
Exactly.
They can tolerate it. Because what is the harm of putting someone on a beta blocker and low dose? If they're tolerating it, they're not going into renal failure, etc. I guess I think of they're going to die from malignancy, and you can treat them with something that's pretty well tolerated, and it can stop the oncologist from having to adjust their chemotherapy. That's what's pretty complicated.
Yeah, and people have looked into the dose of people.
Why do it if it doesn't do You're just giving somebody medications to make you feel good.
There's definitely enough data showing that these help. I mean, I showed a systematic review.
Signals. Yeah. Just started an initial research from every system.
That's true.
And
And they don't interact with drug levels. People have looked at that too, making sure that it doesn't reduce anthracycline levels, and they don't, so.
does it matter how long before, you mentioned how long before the started, exactly how long before, like how many weeks before?
I don't know. I mean, it looks like, they say 0 weeks, but I don't know. Yeah. But yeah, like
It's the day
a warm-up period where you're on for a while. Yeah,
Usually they take like up to.
that's true, because of protein turnover. I agree.
How long you got started, so?
I don't know if we know that. Target dose, so 32 of candesartan is about 100 of losartan, so it's a high dose.
Yeah.
It's not.
So in PRADA, for example, they have a rundown phase, they have to get started dose.
Yeah. We should hopefully find out when they publish this. All right, thanks.
Kurt, I just like funny big pharma.
Big pharma already trying to sell it. They'd be happy to know I go for PRADA or medication, so.
Actually, I just give out your DEA number for everybody that comes by, and they seem quite happy. Yeah. All right. So we're gonna go through probably one of the more not controversial per se, but one of the more interesting and described and discussed frequently across a lot of different cardiology groups about the impact, reasoning, et cetera, for the SPRINT trial, which for those of you that were on AHA or didn't read about it, it is a blood pressure strategy and outcomes-based trial. It was an $80 million trial funded by the National Institutes of Health. So it was a large, big trial. We'll talk about it soon here. So background quickly, a lot of people with hypertension, you're looking at 1 billion among 50 years of age or older. Mainly the isolated systolic blood pressure is associated with adverse outcomes, predominantly because those with predominant diastolic hypertension develop systolic hypertension. And then, so we're going to look at that coming up. So the first thing is the guidelines from JNC 8, right? I mean, this was again, not accepted like JNC 7. It was supposed to come out. There's a lot of controversy behind JNC 8. So let's just quickly look at some of the breakdown. The main thing is age older than 60. Goal blood pressure measurements targets in this group predominantly. If you're older than 60, it was less than 150 over 90. And then if you're less than 60, less than 140 over 90. Then diabetes or CKD, it's a higher titration group. So this came out, about after the SPRINT trial had been enrolling. But you can see here that the JNC 8 guidelines actually were quite liberal in the utilization of blood pressure target and goals, particularly for those over the age of 60. And stepping back, we'll look at a few trials too. So one, HIVET, looking at the treatment of blood pressure in those over the age of 80. And you can see most people have blood pressures of 170. And we'll kind of comment on the historical data here to look at where the systolic blood pressure is during entry for a lot of these patients in the treatment and non-treatment groups. And you can see the resultant treatment for HIVET is you got a decent but not a large decrease in blood pressure from the 875 down to the 150 in the therapeutic arm. And there was an association in mortality and all endpoints in the trial, specifically just titrating a uncontrolled blood pressure in those over 80. The Accord study group, and the reason I'm pulling up Accord is their design of titration was effective, and that is what was used in the SPRINT trial. And the Accord study group was tight control of blood pressure plus tight control of, it was a 2x2 design looking at tight diabetic control. But you can see in the Accord group, they started out at about 140 and dropping down to 120 versus 140 in the diabetic group didn't affect outcomes. I remember, I think I was a second-year resident, but I mean, this was a tough day for the endocrinologists. Everything that they've been doing aggressively for the last 10 years was kind of shown to be ineffective in terms of tight blood pressure control, tight lipid control, etc. And then now on to the SPRINT trial. So the hypothesis of SPRINT was that a lower systolic blood pressure would reduce clinical events more than the NHLBI update panel in 2007. So that was, I call it JNC 7.5. It really wasn't, but this is kind of their goals were in line with what JNC 8 was. So their hypothesis was that in non-diabetics, there is little evidence to push the systolic blood pressure below 150 over 90 and those over 60. So that was the question they sought out to answer for the most part here. So it was a randomized, open-label, controlled trial, 102 sites, NHLBI funded, and we had also talked about the fact that it was a very expensive and large trial. So unlike the guidelines which use 60, they enrolled people 50 and older. Blood pressures ranging from 130 to 180. And they also had to be at increased risk of cardiovascular events defined as chronic kidney disease, a 10-year risk greater than 15%, or over the age of 75. So you had to have blood pressure at least twice in the last 3 months or once in the last clinic visit greater than 130 systolic. And they actually have this table, which we can look at later, which is striating. If you were on 3 drugs, you couldn't have a blood pressure over 160. And they had a pretty stringent enrollment criteria. And then they also had an asterisk saying if you had a blood pressure at one point in time in the last 3 months, you could be enrolled, or if you down titrated the medicine and then met enrollment criteria. So in theory, someone could have a blood pressure of 125 and you take them off their two drug therapy and they go on to 1 drug therapy and their blood pressure reaches the enrollment criteria, they could be enrolled. So they were pretty liberal with the enrollment criteria in terms of if you were already well treated. And then excluded diabetes, stroke. Dr. Francis?
You might say a few words about the medication.
I will get there. I'm going to pull up the appendix here quickly because the appendix actually is a pertinent part of some of the design of the trial. And so, again, exclusions if you're hypotensive, proteinuria. So let's see here. Here is their algorithm, because this is an important thing I think for us clinically is how do we go about treating. So this is for the invasive group, the goal less than 120. You begin with 2 or 3 drug therapy. Are you greater than 120? Yes. And then if it's yes, then you either up titrate or add an additional medication, and you follow up in a month. Now the medications that they recommended using were chlorthalidone, calcium channel blockers, and ACE inhibitors or ARBs were the main. And then if you were on those, they added a diuretic therapy. And they kind of left it to be dealer's choice, but it was chlorthalidone, beta blockers if you had an indication. There wasn't a recommendation for beta blockers, and then ACE inhibitors, calcium channel blocker, with the addition of a diuretic if you were already on those medications.
Did they take it out for Tazone from that, right?
Pardon me?
Would they take it out for Tazone or would they use sequential blocker?
If you are what? For,
So for diabetics,
oh, you were excluded, right, because this is non-diabetic. One of the first, oh, diuretics, pardon me, you know, you have, in addition, so furosemide.
sure,
Yeah,
but they would add furosemide to Tazone?
Yeah. Well, you'll see very few patients were on more than 2 drugs. So
One
that's,
of the criticisms is that the drugs really weren't controlled. So it's up to the physician
Right.
to use whatever regimen they want. Pretty interesting thing is that pharmaceutical companies like these drugs free of charge. And then,
right.
that's not, I think the key thing is that, there wasn't any real mechanisms to sort of, titrate them. Whatever the doctor thought he was supposed to.
And there was really an algorithm based on the timing of clinical visits to get them to a low blood pressure. And the argument for the design and then its efficacy is that it worked, the same algorithm of following up worked in the Accord, and that's why they had used it here. But again, you had I forget which ARB it was that they gave free of charge, but they gave, there was an ARB that was given free of charge from a pharmaceutical company.
Was this an all-comer strategy or did they use a different strategy for that?
It was all comers. Yep, it was all comers.
And after the doctor started either the thiazide or.
Right, right. So it was mainly ACE, ARB, calcium channel blocker. So here we talked about, we had already kind of hit upon that component. All right, good. So one of the other things is how they define adverse events. It is as vague as it is stated here, as a fatal or life-threatening event that resulted in a clinically significant event or persistent disability. And I think that's fair, because are you causing injury? And then they had some hard endpoints too. If you showed up in the emergency room, if you're hypotensive, syncope, falls, electrolyte abnormalities, bradycardia, that automatically got put into an event, but there was an adjudication committee that put the events, the adverse events, if it, as a yes, if it met that vague definition. So what were they looking at specifically in the primary outcomes? MI, stroke, decompensated heart failure, death, and then they also looked at individual components, and then specifically because diuretic therapy was and aggressive blood pressure control, they wanted to look at renal outcomes in patients with CKD. So they estimated a 2.2% a year annual event rate in patients with, I mean, it makes sense, a Framingham risk of 15% in 10 years. That's what they estimated their risk to be in a 2-year recruitment period. You can see about 2/3 of the patients screened were enrolled. So that's a pretty broad study, a pretty inclusive study with regards to enrollment. Now remember those nuances we talked about for enrollment. So you can imagine at the VA, how many patients have a blood pressure less than 140? Probably maybe half of the physicians working there, right? But that's about it. Otherwise, everyone at the VA would be most likely a candidate at least here at our VA.
Can I say one thing about the diabetes really quick, just because that was one of the main things people were invited to include. And it had nothing to do with the trial investigators, it was purely because there's other studies that were occurring at this through the NIH. And so they said we weren't allowed to when we formed the trial design. So
Yeah, well, the Accord wasn't out when they started the study.
yeah.
So the Accord study looking with diabetic and blood pressure management was presented in 2009 or 10, and this was starting in 2007. So it was not published data at this point. Okay, so characteristics, a couple of keys here. I think this is really important to look at. Age 68, baseline enrolling blood pressure was 139.7 plus minus 15.8. So what does that tell us? That you have arguably half of the distribution below the enrolling pressure. Now remember that broad inclusion criteria. You could be you could down titrate meds. It could be 2 clinic visits in the 3 months with a blood pressure above 130. So you can see it was a very tightly controlled group already that was coming in the game.
couple other, pertinent, criteria. What about the quartiles of the blood pressure? Because the question I'm really concerned, what about the guy that's on 5 meds, blood pressure of 180 over 100? How far do I push him down? Does this trial give us answers? Not so clear, because if you look at the percent, it was only about 1/3 that had a systolic blood pressure over 145. So, and it doesn't break it down much more than that. The HDLs were all quite high, and the statin use was about half of the population.
What's the blood pressure in the clinic, three blood pressure, 5 minutes apart, so I mean, what we just referred
Right.
often look at and often high.
Correct.
It really is trying to.
Yes.
So what's your concern with that? Are you worried that the event rate is going to be low because the blood pressure is?
No, in terms of the applicability to all of the I guess the patients that we see, the applicability of the overall trial design isn't as broad. It's a little more narrow based upon some of the entry of the patient.
Perhaps you might commenting about blood pressure measuring at home, ambulatory blood pressure monitoring versus visit. Was that because I know our trial was concentrating on ambulatory home blood pressure measurement? Did that have to be
Blood pressures, the ambulatory blood pressures are better, but what really happened here was, study was stopped prematurely, it's not too good. Forward, and the press release came out from the time, basically said, look, gotta get your blood pressure, you know, to do, really responsible to do that, with all these endpoints. There's a lot of, concern, I think, among the faculty. There's a price to pay, we all know this, to get the blood pressure down low. You are lightheadedness, sympathy, falling down, that kind of thing. None of that, of course, is in the question. So it turned up a lot of, criticism, not to just criticize because of this is what these guys doing, we didn't really have all the data. One lesson we learned is, careful approach. Maybe Mark, you can comment on that, but probably you don't want the first, information to come out of this one.
I would also note that the paper published in the New England Journal, a lion's share of the data was in the supplement. A lot of the data that I'm showing to wasn't even in the paper itself. A lot of the strategy, design, and everything was in the supplement. Of course, it's a character-driven requirement. So again, the trial we just talked about was stopped early. They planned for 5 years. They stopped it at 3.2 years. The overall event rate was 2.19%, so they did a fantastic job of predicting overall cardiovascular outcomes in the group. And so if the hazard ratio for the intensive therapy was 0.75 for our primary outcome, and one of the keys is the mean number of meds was 2.8 and 1.8 for our intensive versus standard therapeutic arm. So only 3 and 2 for the most part. Right.
I don't know your history, but I had tried and it may be to go back to first patient, but I'm not seeing people I knew very little about the patient.
You know, if I could just comment about one thing, I mean, this is supposed to be a target. One of the things I'd like to know, maybe is you know from the results, is it's a target trial versus an attained trial. So, you know, what happens if you're, and I think, you know, the target is below 120, right? And the mean is mostly above that, even in the targeted group. So, you know, how do you deal with that around the target? What are the actual attained things, and how far did they get, and what did they do when it was close would be really helpful to know. You know, there's a whole lot of studies that have been published that say if you compare people who get their blood pressure lower versus people who don't, they're better. But that doesn't prove anything, because the people who get their blood pressure down easily, maybe they're healthier. You know, same with the lipid lowering drugs and stuff. So this is a good design, but, you know, the target treatment was funny, as you said, and, you know, most of the people who were in the conventional arm, they were actually a target to start with. So, you know, and it sounded like they might be able to back off on their drugs and say, well, you know, actually you're too low. We ought to let your blood pressure go up to 140, because it's 132 now, and you know, we want to have a big contrast. So we have a great graph here in the New England Journal. So, you know, I don't know exactly how they did all that stuff, and it might be pertinent here.
Yeah, and it was.
I would be curious, I'm sorry,
No, go ahead.
to follow up on that. This is probably not possible, but to emphasize your point, it's medium blood pressure. Half of the people with low blood pressure.
Exactly, yeah.
And I guess I'm wondering if there's overlap between the two antibody arms. And if there's a substantial number of people, practically, who were actually close, overlapping with those who be less aggressive. Are those outcomes? Where that shakes out. Blood pressure is a continuous, have chosen binary definition, partition that. Look at outcome. But it wasn't as if all the patients could be conveniently placed into one to get 140 and 1. So is there any way that they will be able to go back and look at the 100? They'll be able to go back and look at overlap between the randomized arms. It's not legitimate to compare a patient themselves, those patients. Because there's no flip, and there's the real interpretation themselves. You want to take time to randomization process. But that would be, and the last thing I would say is this leaves you a little unsure about what the ideal blood pressure is for an individual, since there is such a range of blood pressures.
You know, it's kind of interesting just looking at the blue curve on both of these. They actually go up over the first 6 months.
Yeah. So the systolic blood pressure here you can see in the non-intensive group. I mean, I would be given high fives if my non-intensive blood pressure group was 135 in my patient population, and then the intensive therapy was 120. The diastolic blood pressure was 75 and 70 essentially in the standard and intensive arms. So let's look at some of the outcomes here. The primary outcome in the intensive group was 5.2 total and 6.8 in the standard therapy. And in terms of the secondary outcomes, I think what we care most about is death. And there was a 1.2% absolute risk reduction in overall mortality in that group, which brings your number needed to treat just below 50. In terms of greater than 50% reduction in GFR, now this is a little hard in terms of what this actually means, because if it happened once at all during the study, it was marked as a yes, and it didn't mean, it could have meant that you were over diuretic, it could have meant you had too much, your blood pressure was dropped too much. So we don't really know exactly how that impacted the trial, but you can see that there is about no difference in greater than 50% reduction in GFR between the two. So that is a good thing. And those with worse renal function, you did see an impact in the intensive arm, which makes sense. If you're predisposed to have worse renal function, you're more sensitive to the adverse effects of hypertension or diuresis.
One of the things that every time I see this, I find it so striking is that if you have a difference in death from cardiovascular causes,
What is it?
and you have no difference from MI, no difference from ACS, no difference from stroke, this is what I want to see, I think.
Let me show you. Good question. Oh, this is nice. So number of agents, utilization of meds during the visit. This is kind of, it helps you look at what they had used. Average number of meds, you can see that very few were on, some made it into the 4+ in the intensive arm, but very few in the standard arm. Calcium, kind of the standard potpourri, 3/4 of ACE, so 50% were on thiazide, and then only 9 versus 4 on the aldosterone antagonist, calcium channel blockers, about 50 and 3/4. But here, sudden cardiac death seems to be one of the main drivers of the death differential, potentially. Strokes, but really the sudden cardiac death 2 versus 11 was one of the main differences.
All-cause deaths would be reduced as well.
Correct. And that was the question: is what are they dying from? And the numbers are low. You're looking at yeah. So that was here. We keep going. Continuing. So primary outcomes. Again, the breakout graph makes it look more significant, but the hazard ratio is 0.75. Death from any cause, improvement, hazard ratio 0.73. The number needed to treat was 61, 90, and 172 to prevent the primary the primary outcome. And the forest plot. This is interesting in that no matter, some cross one, but almost every subgroup analyzed showed at least a strong, in contrast to the Jessup study, which showed the non-intention, this was almost a benefit across the board, and then where you cross one, the numbers are quite a bit lower, particularly looking at the events. And so it does seem to favor it in the intensive group when you look specifically at subgroup analysis.
Can you say that one more time? So the other thing that I think is very bizarre or unexpected was in the greater than 75 year category, right actually where your arrow is right. It was, that's the group that we, over the past few years, have been relaxing in treatment. And that one and this one seems to be completely the opposite.
Let's going, and so serious adverse events. I put all the text on the bottom. Oh, sorry, I didn't realize that I had not given this text the full screen. The serious adverse events, you can see that they were higher. So the number needed to harm here, if you look at serious adverse events, was lower than the number needed to treat. But you're looking at death versus a potpourri of adverse events, which included syncope, injurious falls, and if you had electrolyte abnormalities, is that really something that's obviously quite different from death? But emergency, so remember they took all comers versus the emergency department, and you can see that the syncope held through is occurring in the intensive arm the most commonly. Injurious falls, which we often worry about as being a big problem, actually was a wash in both groups. And orthostasis actually also was similar, but I couldn't quite explain this as why orthostasis was worse in the standard therapy group versus the non-therapy. So I think the strengths are, we've kind of talked about a lot of them. It was a well-run trial in that they achieved their goals. It was broad, and it's easily applied in that there's not a very tight strategy for controlling blood pressure, but the unknowns are who actually you have in your patient population that's a non-diabetic who's on 2 drugs and whose blood pressure, 2 to 3 drugs, and have pretty good blood pressure control. So the applicability in the generalized patient population that we see is far more limited than what the trial originally looked at. We can just bring everyone's blood pressure down to 120. In actuality, it's much more nuanced than the broader stroke that the trial paints. Any other questions? I think we've had it right.
Just done it the other day, but I just remembered that more side effects is the intensity of treatment. On the other hand, the outcomes is that, I guess the real question is now, how is this gonna change practice? Is it gonna change practice, or?
I'm actually concerned on the side that you had brought up, that I think even just reading the paper without digging through the appendix, you kind of think, well, yeah, there's some side effects, but if I look at more patients will live versus some having some electrolyte abnormalities, maybe I over-diurese someone, or, some kind of difficulties, but not fatalities. They say, well, we can go ahead and let's be very aggressive with blood pressure, but the problem is that there's a lot of selection in who this actually applies to based on how the trial was run, where if you just apply this to all of our patients that come through the door, I think that the adverse events will be far worse than the actual benefits that we'll be able to gain.
So I think commenting on the, like you mentioned, the non-fatal debilitating effects such as non-fatal strokes, fractures that will debilitate the old people, and the long-term effects, because those will not kill you in the short term.
Well, strokes were better. I mean, that was, it didn't matter if it was fatal or not, that was in the composite endpoint.
For a trial that is internally balanced.
Yeah, I agree, it's internally.
Now, you wouldn't treat all comers. They have to have a reasonably high risk. In the appendix, you show that the average rating risk score,
20%.
15 as measured. I have to remember from the appendix, as you give someone on the calcium score, it's 400 with a high risk. But high risk, moderately high risk, general population, but not mandatory for everyone. By the way, I have a little qualm about the number needed to treat. When we stop trials early and overstate that edit, notice they have 500 endpoints. Chances are that there's no large enough study with enough endpoints. That might be a slight out.
I had just a couple of comments about the sort of this asymmetry whenever we do trials between the efficacy endpoints and the safety ones. And part of it is like, okay, we have a well-defined, focused group of efficacy endpoints. And so we look at those and, we're monitoring people very carefully for MI in this study. And then, but the bad things that happen to people can be all over the map. And they're not, they're a little squishier. And sometimes they don't, come out and they're not looked for as hard as the efficacy parts. And so sometimes it's a little harder to figure out what the harms side is. And, maybe there's an unanticipated one that didn't come, like one of the things that shocked me was that we only figured out that in the statin trials that there was an adverse effect on diabetes after like a gazillion trials had already been done. It's like, wow. I mean, we couldn't figure that out sooner than this. I mean, so one of the issues, I'm waiting for the other shoe to drop in terms of getting more on the quality of life side of things, and functional issues for people. I mean, it's like, okay, yeah, they didn't go to the emergency room because they fainted, but they actually feel crummy, or their sex life went to hell, or some other kind of thing that made them unhappy, and maybe that's we don't know how much more they're getting from that. So that's just the safety thing, and in terms of like cost effectiveness, very small decrement in your quality of life could flip all this around. So it's important to know how they did that.
Pretty intense monitoring. You can imagine seeing every patient with blood pressure elevated once a month. I mean, that's a lot of clinic visits. I mean, so that's a lot of work, and a lot of cost for the healthcare system. It's yet to be determined if there is overall benefit.
Could you go back to the forest plot for a second? I mean, there was one thing there is, you know, the thing on the bottom, I think, is fascinating, and I haven't quite figured out what I think the story is there, but, you know, I was kind of expecting, depending on your entry blood pressure, you'd see something different. But I was thinking it would go in the other direction. And it's fun, it's nominally not significant, but it's fairly striking that actually the biggest effect was in the people who had the lowest blood pressure to start with. And
I was like, explain that, or comes the argument that the lower your blood pressure is, the more benefit you get, because the ones who start lower, they get even lower. Whereas maybe people start at 145 got down to 135.
Yeah.
You see as much of a benefit, but the average for that group is still less than 120 because the lower people went lower.
well, I wasn't sure because it seemed to me like if you were randomized to less than 140, you'd say done, or maybe they were actually backing off medications in that group. I don't know. It just seemed very weird to me that they would randomize somebody who was already at target.
And I also think this probably has something to do with it too, is presumptively the patients on the higher strata where polypharmacy was becoming an issue, and, they were the ones on the most medications, presumptively. If you're on 4+ medicines, and given how the treatment protocols are working, you are probably requiring more medications to up-titrate. So that's also a possibility too, is that you're running into untoward side effects of medications and interactions with us each day. All right.
Well, I have one other point. As far as applicability, if you have a patient in your practice, everyone, do you think it's reasonable that if you can really get somebody down to a lower goal without the side effects, without the quality of life, then I think that's what you were saying, you try to limit. And so, in a way, I think this was by far the most publicized trial of the AHA. And people walked away and said, oh my goodness, we have like brand new goals and do everything. And in a way, I think it's something that people may have practiced in some level in the first place. So it's easy to get somebody down, we can do it without you don't understand the side effects. If you can't do it, then you can't do it. And probably have a worse prognosis rather than
So it's clear as mud, right? $80 million and clear as mud.
Well, it is disappointing from the clinical trials but I'm waiting whatever happens in the chase shape, when you had thousands of articles in the last years about blood pressure